All right, I think we're live. Hi, everyone. This is Barbara Phillips, and happy Nurse Practitioner Week to everybody. I am going to make our chat public for everybody. And right now we've got 20-some people in the room and more joining.
Excellent.
So this is our first hangout for both me and for Troy. And so this is, I don't know what to tell you. We're just going to go ahead and get started. I think you should all be able to see a chat box, and I see people are saying hello, so that's fantastic. So hello to Catherine and to Tijan, who both said hello. And then we also have Katrina, Phyllis, Andrea, hi. Debbie's here. Brian, Brian, you must be my brother, Brian Phillips. Okay. So lots of folks are joining us. And so tonight we are here not only for our first teleseminar, but we're going to be talking about telemedicine. And I have with me tonight Troy Heidesch, who is the CEO of Smart House Calls. And, you know, this whole call came up because of a conversation, I believe it took place on LinkedIn, about telemedicine, and I had suggested somebody look at your system, Troy, and there was some more conversation, and you had suggested, hey, let's just do a hangout, so that's what we're doing. So, Troy, why don't you go ahead and get started?
Sure. Well, thank you, Barbara, and thank you for putting this together. This is fantastic. So if anybody has any curiosity about telemedicine, this is essentially what it is. And I use that term telemedicine with some trepidation when I'm talking to nurse practitioners, because we tend to be very cognizant whenever medicine is used rather than health. Let me sort of start out by saying I'm there with you. The problem with the definitions for telemedicine and telehealth is that telehealth really encompasses both video, audio, asynchronous technology, weighing patients and recording vital signs that go back to a center, even right down to those fitness apps that you have on your smartphones can all be considered and are all lumped together under telehealth. But when people talk about telemedicine, really what they're talking about almost exclusively is a live two-way audio-video interaction with a patient or a client, and that's why I use that term. So forgive me, please, nurse practitioners. I'm there with you. I understand. I'm using that simply for clarity. But you know, a little bit about me. I know some of you know me. I've talked with many of you over the past year, probably. Quite a few, actually, since Barbara and I did our first conversation together. But I started Smart House Calls about 4 or 5 years ago. Started out with this idea that, you know what, I see patients in the office, and we're probably all used to that. We have them come back after we do some lab work or physical. They come back, we talk to them, we spend 15, 20, 30 minutes with them going over the lab work, talking about lifestyle modification, talking about perhaps medications that we're going to put them on, and we never really lay a finger on them when they come back for that visit afterward to go over everything. And invariably I would get this look from patients like, you made me fight traffic and sit in your waiting room for 45 minutes and you just talked with me. Why the heck couldn't you call me on the phone? And the answer is simple. If we're going to spend that much time with someone, we have to be reimbursed for it. We can't do things for free, especially for that long of a visit. And rather than a 2-minute phone call, maybe it's better to bring them in and have them see us so we can go over and go through all this and unpack all this stuff. Well, in a way, sort of an epiphany came, well, why don't we use telemedicine technology to connect to patients at home? And then we can charge for the visit in many states and in most insurance plans. We can charge for that. So that said, let's build a software, let's go out and test it, let's start it. And we started there, and now we're moving not only in software sales, but we're also doing really placement. So of our providers who have come on board and are using the software, we actually find organizations that need their services and help them contract with these larger organizations to deliver care.
So for for nurse practitioners, for all of us that are sitting here, okay, this is a great, this is a really wonderful service, but then if we want to maybe add this to our practice or maybe even start a business using this, what would we do, and how do we know if we can get reimbursed, and how do we know what works in our area?
Okay. Well, reimbursement obviously is always key, right? We need to pay ourselves, we need to pay our employees, so that's a big deal. The nice thing is that year by year, really almost month by month, more states are coming online. And I just recently looked up Missouri, and I wasn't even aware of it. They're not even on my my PowerPoint presentations that I do. And they, since 2013, have required insurance companies to pay for telemedicine. So I think we're in that probably half of the states require private insurances to pay individuals the exact same amount as if that patient came into your office and sat down in front of you. So that's the good news. The other part is that Medicare in all 50 states pays for it at the same rate as a face-to-face. Now, the only caveat to that is they want someone to either be in a suburban area or a rural area, and they have to be at an office or some place that can already charge Medicare for services to be a qualified center to see the patient. They don't want the patient at home. You can certainly see Medicare patients at home and have them sign a form that states that they understand they're going to have to pay for this out of pocket, that Medicare won't pay for it. And many are willing to do that because they're tired of driving in to see people. And then Medicaid, I think we're at 45 states now that require Medicaid to pay at the same rate as if someone came in face-to-face, and they operate under the Medicare rules where they want that patient to be in a location, a clinic of some sort, a rural hospital, a school health center, something like that, to be seen. As far as for setting this up, typically it's pretty simple. It really is one of those things where, from our perspective, and there's lots of vendors out there, Polycom, Cisco, Tandberg, they're all great companies. They all have software services that do this. But like ours, and I don't know how easy it is to get theirs up, but I know with Smart House Calls, it's simply an email to or a call to our call center, and effectively you can get the switch flipped on in as little as 24 hours, and you can be practicing telehealth.
So not only, one second, Troy, I'm sorry, we have several questions coming in now, so I do want to just remind people that if you do have questions, go ahead and put them into the chat box. So one of the ones, Nancy is asking, this will stop scrolling here, Nancy is asking, she's curious about the technology part of this, and she notices a difference between the audio and visual between both you and I, Troy. And I think some of that, Nancy, is just lighting is big. I have a whole bunch of lights on in the room that I'm in right now, a lot of overhead lights and side lights that I think help make things brighter. But she's also wanting to know about the best technology to use so that you do get a good connection with your patients.
Sure. So so talking about Google Hangouts and what we're doing here, essentially, I believe that Barbara's is set up to where it's an HD signal that's going out. In order for us to have a normal conversation, Google Hangouts on my end degrades my resolution a little bit to make sure there are not going to be any issues, so that's probably why I look a little different. But Barbara, you're exactly right. When you've got better light, the cameras, those sorts of things, you're going to get a better image, if you have the bandwidth capability. So, and when we talk about bandwidth, typically what we say is we want you hardwired in. So rather than working through Wi-Fi, you really should have a cable plugged into the computer that you're using. You should have plenty of light. The Department of Defense recommends a light blue background behind you. It's a recommendation, but the reason we do that is sometimes a white wall can reflect and cause the image to sort of white out or darken a little bit if you're using lights. And the biggest trick that when we're teaching people to use this sort of video conferencing for the first time is to wear basic colors and have a plain wall behind them, because anything that moves on that screen is a piece of data that's sent through your internet pipe, and so the lower the amount of data that's sent through, the better it's going to appear to the other side.
Well, and I just want to say too that everybody does tell us when we're doing Hangouts or anything that's video and anything that's online, we should be doing it being wired in, so hardwired in, having something actually connected to your computer with a wire. And I have to tell you, I'm on Wi-Fi because we don't even, my computer doesn't even have an Ethernet port. My laptop doesn't, although I am on a desktop. But so I think there's some variation that can happen there as far as, do we use the Wi-Fi? Do we use the Ethernet? But you know, what about, Troy, if we're using things like an iPad? Shouldn't we be, in our smartphones, shouldn't we be able to use those with the software that's out there?
Yeah, most definitely. Not all software will do that. I can speak for Smart House Calls and that we have that capability. But we do recommend that providers use a regular laptop or a desktop because the software that we have to write, the apps that we have to write for those mobile devices have to be very, very small. There's not nearly as much capability in that, and it makes it much easier if you have the patient happens to be on the tablet or a smartphone than you are. And on top of that, it's really recommended, I know the DoD and I know the American Telemedicine Association recommend that you have at least a 17-inch screen when you're looking at a patient. From the patient perspective, it doesn't matter really what size your image is. As long as they have a good camera on their phone or their tablet, you can adjust and look at things on a bigger screen just fine. But once you start shrinking that down, in order to be able to do anything that's somewhat diagnostic, and that even means facial expressions, it's better to have the larger screen if you can. But emergency situations, you know, you're away from your desk and something comes up, you certainly, there are many software programs out there where you can use a mobile device.
Okay, we've got a lot of questions, so I'm going to just keep going with questions here. Lori is asking, do I have to be licensed in the state the patient is calling from? If they're in West Virginia, can I do telemedicine, say, in Maryland?
Yes, absolutely. Now, I'm going to put the caveat out here that I'm not a lawyer and I'm not familiar with state laws, but from every state. But it is generally understood that if you are going to see a patient by telemedicine, you must have a license in the state where the patient resides. So if you are calling from Maryland to West Virginia, you should have a license in that state as well. There is a lot of work going on, and I know the American Telemedicine Association it's a lobbying group in Washington that is pushing very hard to make reciprocity happen. I know the VA is also working very hard to change the rules where if you are in the VA system, you can see patients no matter where they are located without having problems with each individual state. But each individual state has its own board that is responsible to their communities in that state, and they want to make sure that you indeed are not some charlatan seeing patients and causing some problems.
Oh yeah, we all have snake oil in our bags, right?
Exactly, especially as nurse practitioners.
Yeah, I know. All right, Dennis is asking, the reimbursement is still less 15% compared to that of physicians. Is that correct?
Yeah, it's
Dennis, if you're talking about Medicare, then yes, definitely.
Yes, that's it. And then that also depends on your individual contracts. Mm-hmm. If you're contracting with Blue Cross Blue Shield, you may be able to get more. But typically with the parity laws, all that says is that whatever you're being paid for them to see in your office, you should be paid the same rate if you're seeing them through a telemedicine visit.
Mm-hmm. Okay, Brian has a couple of questions here, and I think this one was kind of answered, but I'll put it out there anyway. Any advice for NP setting up teletherapy, and I'm going to assume, well, maybe it's not, psychiatric therapy, I think is what he's asking about, across state lines, particularly so that both patients and providers can be in the comfort of their own homes. And then he's also stating that Oregon reimbursement is supposedly at parity with non-NP providers, which I don't know if that law went into effect. And I don't know, Brian, I don't know, and maybe you can put this into the chat box. I know that Oregon got parity, but did that also include the government programs such as Medicare, since that's more of a federal program?
Yeah, and I would say probably not. Medicare and CMS is completely different because it operates at the national level. They can dictate different rules than each individual state will. So I would say probably not on that perspective. But if you're talking about setting up a therapy, telemental health, telebehavioral health sort of a network, my personal experience, and this is really what Smart House Calls has gotten into over the last 10, 11 months, in that we go out and actually find and deliver contracts to our clinicians who have signed on, and I like the model where rather than trying to hang a digital shingle and provide services for patients online, that you're essentially connecting and contracting with a center who's just going to feed you patients, and rather than having to wait a year, 2 years, 3 years for your business to really take off, once you have that contract, essentially you're booked, or a couple of contracts, you're already full and you're looking for other NPs to join your teletherapy business.
Okay. Franklin is asking if you would mind repeating the resources or companies that can assist with setting up a telemedicine practice.
Sure. The biggest one everyone talks about, and they have some fantastic networking events across the U.S., is the American Telemedicine Association. And I think it's americantelemed.org or something like that. But if you type into Google American Telemedicine Association, you'll pull up their website. They have all of the state data. They have guidelines and policy and procedure manuals. They've got a lot there. I think membership with them is about $350 or $400 a year, something like that, and it's invaluable. And then those conferences are absolutely spectacular because telemedicine is, I say it's somewhat new. It's not. It's been around for 50 years, but it's really accelerated over the last 5 or 6 years. And because of that, and because it's so new to so many, when you go to the American Telemedicine Association meetings, most of the sessions that are there are other entrepreneurs who have started using telemedicine, have developed their own telemedicine companies, and you get to sit in there and listen to how these people did it and devise your own business plan based on what they've already done.
All right, so it sounds like they really give you a lot of resources to get started.
They really do. And by all means, my email's out there. I love helping. So if anyone has any questions, feel free.
All right. Let's see. Angel, thank you. She is thanking us both for being here tonight and offering this webinar. Debbie in North Carolina, she's asking, are there specific mics that you would recommend, and what about earphones?
That depends. If you've got a good computer that has, a lot of computers now are being built for entertainment, so they'll have good speaker systems and good microphones. Just about every, right now I'm more on an HP with an embedded camera, and the speakers are included, and things are working out well. When we set up hospital systems with this service, generally what we do is we have them, the Smart House Calls does live audio and video through the software, but we even take it one step further because we want to make sure that the audio is really the most important thing. We don't want to lose that. So we have a speakerphone that is put in the room. The people dial in between the two clinicians using the speakerphone, and then the video on a computer screen, and any HD camera will work with that. So I don't have specifics on what specific sort of speakerphone or headset, that sort of thing, to use. I will say from experience that wired is better than Bluetooth, and the only reason is invariably someone will have a hard time getting their Bluetooth to sync, and you're sitting there looking at each other for 15 minutes trying to get that to work. It's just easier to use the wire and plug it in. So I would say that on both ends. But typically, if you want a fail-safe thing, use the telephone and a speakerphone for your audio, and then use a telemedicine vendor for the video.
And I would actually say if you've got, like, you know, I've got one of these. A lot of people are using just the earbuds with the mic part. I just don't have my mic part turned on. But apparently the audio is really, really good. And I know that a lot of people, because I do podcasting, a lot of people are even using these to go ahead and do their podcasting. The audio is that good. So you can certainly just use your earbuds that came with your iPhone or with your Android phone.
Yeah, I'd also recommend that if you're going to be doing any of this using a mobile device, that's actually a necessity. You may not have to have earbuds and a microphone if you are on a desktop computer or a laptop, but if you're going to use any sort of mobile device, they are not, the speakers and the microphones are just too close together, and you will get feedback and dropout unless you actually plug in something to that.
Yeah, and I just have this plugged into my computer tonight. Okay, Angel is saying, are you aware of the new CMS telehealth reimbursement ruling issued October 31st? In your interpretation, has this changed what you just mentioned about rural versus urban reimbursement? I think, let's see, I can send a link to the ruling if needed. Thank you.
Yeah, it has. Yeah, I am familiar with that. In fact, Barbara and I were just speaking about that before we launched this tonight. But yeah, so if you're in a suburban location, if you're in a rural location, they still do not recommend it under, they still don't pay for urban to urban sort of work, which I'm hopeful that will change. But the big thing here too is also in that chronic care piece that they're also going to be paying or reimbursing clinicians for the chronic care component, and I think telemedicine is a big part of that if you want to maintain that ability to connect. Now, I have not seen anything, and I haven't read the whole thing yet, but there may be some loosening too on where the patient is located. But for right now, I'm just going to say that the patient should be located, in a facility of some, or clinic of some sort.
And when we had talked the first time, Troy, you also said that the patients could be in a facility that could bill for Medicare, and that even included a school.
Yes. If any clinic that is set up, whether it's a school-based clinic, a workplace clinic, a traditional office, all of those, rural health centers, hospitals, those sorts of things can all be the site where the patient is located.
Okay. I hope I'm not going to butcher this name. Rabami. I'm a newer NP, and I was just offered a position for telehealth and was apprehensive because this was a new way to deliver patient care, at least for me. What is your perspective in regards to a newer NP practicing in this structure?
That's a great question. I've always been, and let me put this out there as well. I'm also the graduate nursing chair for a university in Georgia, and I'm responsible for setting the program goals and doing everything that we're doing, not only for our nurse practitioner program, but our master's in leadership and our DNP program, so our Doctor of Nursing Practice program. And one of the things that I've always sort of preached is that first year out as a nurse, really in the academic setting, we only have so much time to teach, and you have only so much time to do clinical. And I think generally speaking, it's probably around, I think the minimum that CCNE requires of universities is 500 hours. That's just not nearly enough time to really dig in. What we find in the way that the brain works and the way the brain retains information is not only by reading and doing the didactic work, but getting your hands in there and working. So my thought is that from a telehealth perspective, I would be apprehensive unless I was working in a clinic with other nurse practitioners that have been working for a while, or physicians who have been working for a while, that when you run into issues, you can bounce some of these things off of, and you have some time to do the research, you know, look at your evidence-based practice, up to date online, those sorts of things, to figure out what's the most appropriate way to treat this, and what are some of the differential diagnoses I need to think about as I'm talking with this patient. So if you're isolated and you're at home and they're saying, yes, you can just practice from home, I would probably, as a new NP, be a little bit leery about that and might want to get my feet wet, working 2,000 hours in a very busy clinic, and really go through and dig in and learn that first year.
Absolutely, and that's exactly what I say when new nurse practitioners come to me, or they write me and they want to start their own business and their own practice. You've got to focus, if you're a new nurse practitioner, on becoming that expert clinician before you start going out into the fringes, if you will. Because this is still pretty cutting edge for a lot of people. And you know what? We are still educated in a way that we're educated to go and work in somebody's clinic or somebody's hospital. We're not educated to go really out on the fringes of care and some of the more cutting edge things. So yeah, that was a great question. Rosalie has a couple of questions. She's asking, what code do you use for telehealth, and how do you charge for the call, by time or by problem?
They can go either way. The code, typically speaking, from a family practice perspective, it all really depends on the number, the complexity level. I will say that if you do a very detailed review of systems and obviously a very limited exam, if the patient's at home or just in another clinic, I usually get the EMR software will recommend a 99213. The only thing that's different is Medicare wants you, and most insurance plans would like you to add a modifier at the end of that. So you would, and that modifier is GT, which signifies that this was a live two-way audio-video evaluation. So you would say 99213 GT to indicate that it was level complexity of 99213, and then the GT modifier saying that was over video conferencing. Now, that said, it's very easy to do a 99214 or even a 99215 if you spend 45 minutes to an hour with the patient, but you need to make sure that you are actually in a session with that patient that entire 45 minutes to an hour. You can't log off or review their chart and then come back, and say, and be 15 minutes with them and say that that's worthy of a 45-minute consultation.
What are you using as the place of service?
The place of service would be typically where the patient is located. So if they're in a clinic somewhere, you'd use that clinic location. Otherwise, if you are remoting to a patient who's at home, you'd use your own established clinic where you can bill Medicare or other services. Now, if you're talking about cash pay, it doesn't care. You can charge whatever you want.
Mm-hmm. Right. Let's see. Michelle, how do you feel comfortable prescribing medication without being able to see down a patient's throat, listen to their heart, see their skin?
It depends on the patient, and it depends on your relationship. I'm one who I really recommend that you know the patients first, that you've seen them in face first, so that you get to know them. And if you can't make a diagnosis, if you can't get enough information to do that, then you need to see them. Generally speaking, if you have a client who's in another clinic and you're remoting, you have a contract with another clinic and you're providing services there, and they have the ability to have a digital otoscope, digital ophthalmoscope, digital stethoscope, those sorts of things, well, you can do a lot with that sort of thing. But if you're connecting to them in their own home and they're using their camera on their computer, that's not so easy. And I would probably say if you don't feel that you meet the minimum standards to be able to diagnose that, then you can't do that. They have to be seen. I will say this much. I have done with our own software where I've connected with a pilot who was was in another state. I had a license in, and he had fallen and scraped his leg. And so as I'm talking to him, he could not, from the embedded camera on the computer, be able to show me his leg adequately. So I told him from the smart house call system, I said, hey, take out your iPhone, turn it on, load this app up, and he, simultaneously as I was talking to him on his computer, he was showing me his leg in another window using his iPhone. And in that case, I could make an accurate diagnosis. I could see that it was fine, it wasn't inflamed, there was no signs of infection, he wasn't giving me the right sort of symptomology, it was simply an abrasion, and I said, no, you don't need antibiotics, make sure you keep it clean, bandage it, and then follow up with me in the office when you fly back into town.
Now, Troy, was this someone that you already had an established relationship with? Okay.
Absolutely. I have never, like I said, I don't recommend ever hanging up a shingle, digital shingle, and having never either never seen the patient, or they're not in a safe location where you can talk with other healthcare professionals that are at that location and learn more about the patient before you see them.
Right.
I'm not one that there are several companies out there that will simply put out a shingle to see a patient that you've never seen before, and I think you really set yourself up for some real headaches if you're not ultra conservative with every single patient.
Yeah, I've certainly seen a lot of that. In fact, in my own state right now, Washington, I had gotten an email about another company setting up a service for nurse practitioners to see patients, and they wanted to do a pilot coming up, I guess, over this week, last weekend, or the weekend coming up. But the whole thing is in some cases, I think you could probably at least triage a person into a situation, but I would feel more comfortable, and I see the best use of this as an extension to the patients that you already are seeing.
Exactly. I think it makes a lot more sense to state boards as well, when essentially what you're saying, if you use it in that sort of format where you already are established with the patient, you've seen them face to face, simply what you're doing is you're actually improving care by, rather than diagnosing them with a phone call and trying to treat them that way, that you're adding in a video component, and you're able to get so much more information when you add in that video. So you're actually increasing the standard of care.
So Brian is asking another question, and Brian, I'm going to ask you to give us some more information. Where did the question go? Because you said, what about kickback rules on that? So I don't know exactly what that means.
Oh, he might be talking about if I am, Smart House Calls right now is connecting providers to organizations.
Okay.
Yeah, we do not. Okay, so essentially what we're doing from the Smart House Calls perspective is we are negotiating the contracts similar to what a locum tenens company would do. In fact, it's the same thing. It's just like a locum tenens company where we're providing the services, or we're providing the people to get there, but we don't. We're not getting paid based on. So how's the best way to describe that? If the clinicians aren't paying me based on how much they see. I guess that's what it's like. It is definitely not kickback in that sort of way.
Well, and the other thing, if you really read the Stark laws, they don't really apply to us. We're not really covered under Stark laws, at least not at this point in time. At least that's how it was the last time I went through and read it. It was directed specifically at physicians, so not at nurse practitioners and PAs.
Exactly.
Phyllis is saying, can we clarify the location that the patient has to be in?
Okay, so if I could, I'll give 5. Essentially the easiest way to think about where the patient has to be is A, they can't be urban. That's basically it. So they couldn't be in the middle of New York under CMS rules, and you be able to see them at a clinic in New York.
And again, that's insurance. That's not cash.
Yeah, private pay doesn't matter. If whatever your contract states, or if you're just charging the patient outright, it doesn't matter. But from Centers for Medicaid and Medicare Services, they're going to require that the patient not be in an urban location. So essentially what you would do is just go to your state map, you'd find out what the urban locations are, and you could not connect to those locations to see a patient. You could connect from those locations, and anything in the suburbs or in the urban areas, you should be okay to see.
Okay. Okay, and then you said that there were some other locations, so they have to be in a school or a church or somewhere that has to.
And the easiest way to state that is if they have to be somewhere where that clinic can charge Medicare and Medicaid for services that they're rendering.
Okay, Renetta, have you seen successful primary care practices done via telemedicine, such as diabetic care, hypertension, acute episodic visits, etc.?
Okay, so typically, that raises a really great idea. And I'm currently as that chair of the nursing department. We are the graduate nursing department. I have a student who I'm their committee chair, and what she is doing is she's connecting a diabetes educator from a hospital system to a primary care office that's about 30 or 40 miles away, and it's a hardship for those patients to go there. And I think that's a perfect sort of model. And one of the things that I think would, as we're looking at the data, and it's been amazing to see the drop in no-show rates when you do that, when they can go to an office that they're already comfortable with and see a diabetic educator without having to drive and then go through this big hospital system to try to find the diabetes educator office. So that makes a lot of sense. The A1C levels are going down, but they're not as much as I think we would all like to see. And my thought is that the diabetic educator maybe can't do enough. They can make the recommendations, they can show the patient what to do, but at times you need to adjust medication levels or you need to adjust treatment regimens. And I think that's where a nurse practitioner who maybe has gotten a certification in diabetes education as well can hang a shingle and be connected to clinics and deliver specific diabetes education and management expertise to that clinic to improve A1C levels and maybe BMIs for patients. And I think that's really sort of a dynamite opportunity that really hasn't done much yet. But I think that's, and I talk about that because there's a great article written by Michael Porter, who's a preeminent strategist, probably one of the preeminent strategists in the world, business strategists, and he recently wrote a book called The Solution That Will Fix Healthcare. And he points out that all the data shows that the more you do a particular thing, the better the outcomes are for the patients. So he gives the example of a surgeon, an orthopedic surgeon who does 6 total knees a day is going to have much better outcomes than an orthopedic surgeon who on one day may do 1 knee, maybe he'll do an elbow and a shoulder, and then maybe he does 2 or 3 of these procedures a week. He's just not going to have the type of outcomes that someone who just does it over and over and over and over again. And I think that's the case that can be made for nurse practitioners who hyper specialize in something, whatever it is, and then use telemedicine to deliver their services to a network of clinicians that need that specific expertise for those patients.
Mm-hmm. Mm-hmm. And that goes to, for anybody who's read like Malcolm Gladwell, he talks about 7 or 10,000 hours to get to expert status.
Exactly.
Yeah. Let's see, Franklin. I'm a new nurse. I'm a new grad NP. How safe is patient data and the information with the software out there, and is how telemedicine So I think what he's asking about is safety issues, and then also data safety and confidentiality and HIPAA and all of those things.
Okay. Well, first of all, I need to point out that anything that you use that goes over the internet is not 100% safe. And if anybody's paid attention to the news today, they found that about 800,000 employees for the U.S. Postal Service may have had their Social Security numbers and personal identification swiped. You know, one of the big scares out there from the technology perspective for the Affordable Care Act and the setup of these exchanges is that the data security isn't there, and it looks like it's fairly easy to hack into that system and steal patient data. At this point, they haven't fixed it yet, and I know they're working on it. So anything that you do that goes over to the net is not 100% safe. The only way that it's safe is if you completely unplug from the internet and you have a hard drive sitting in your home that you use and software that you use without ever connecting to the internet. So, but we don't operate in that world. So what are some of the things that you do? Well, the very top thing that you need to do if you're going to be using any of the software is you need to make sure that you get a business associate agreement from the company that you're going to be doing services with. And what that does is, in case there is a breach by that company, it shows that they have said that they're HIPAA compliant and that they should be held to the same standards as you are, and so that if there's a data breach by that company, they don't come after you. You can say, listen, I had a business associate agreement with this entity. They're the ones that look like they're at fault. You're going to need to call their representation to get this thing clarified. So that's probably number one. And then just, you know, make sure that you do your research on those companies that you deal with. But generally speaking, you've got a lot of leeway there once you get that business associate agreement from those companies.
And there is a lot, and I mean, this is a whole another webinar to be talking about compliance and HIPAA and safety issues. But, you know, make sure that you're looking at your own equipment, and is your computer encrypted? Do you have some kind of safety net for your tablets and your iPhones and those sorts of things? But like this is a huge issue. Malcolm, I'm going to go ahead and address this. Malcolm is saying that my picture looks a lot clearer and wonder what I'm doing differently. And so, Malcolm, I'm on a Mac, and not that I think that that's what makes
I'll give you a break.
Differently, no, but I'm on a Mac, but I have a lot of light around me, and that makes it a lot easier. A lot of times if you don't have enough light, you know this just from your own photographs and your own videos that you would be doing, you're not going to get real clear pictures. So that may be part of it. I think both of us are on Wi-Fi. I have a high-speed Wi-Fi, but you know, different Wi-Fis are going to have different bandwidths, and that makes a really big difference. Troy, do you have anything to add to that?
No, that's probably part of it. I will say that what Google Hangouts does is it looks at the bandwidth speed that you have, and it adjusts the image based on that so that you can have the best sort of outcome. I know that I'm sitting, as you can tell, I'm in my home office. This is 8 o'clock on the East Coast, so I'm sitting at home. And my upload speed for this video is really slightly above dial-up, which is why my image may look a little bit more grainy. But Barbara's absolutely right. If you've ever taken a picture with a cell phone in a darkened area and it looks really grainy, that's because it's too dark and the pixel density is different than when you've got a full light. And unfortunately, this office is not set up well for the type of lighting that Barbara has.
Oh, I just jerry-rigged things together. You would be surprised. Let's see here. Nancy is asking, if you are a direct pay telemedicine practice, what do you use for processing credit cards, especially since you cannot have the patient sign?
My personal favorite, and this is just because this is what I've been using, is Intuit QuickBooks. They've got a QuickBooks online that they can give you their credit card information and put that in. You can also, and I don't know if they do this, I'm sure they may do this, But there are other services out there. If you talk to your bank, online services that process payments where the patient themselves could put in their credit card information before they ever saw you, and then you see them that way. And you know, one of the top ones that comes to mind is PayPal. You can integrate PayPal within your website, and for instance, we can do that with smart house calls where the patient pays, and then once they do that, they can then access the part of the website that has the software on it where they can see you at that point. So, and, you know, so PayPal is an easy one. I mean, it's free unless you want to completely white label it, and then they want to charge you some money for that. But otherwise, it's a great service to use, and just have the patients put it in.
Yeah, there's all kinds of online payment options that you can use, and definitely start with your bank, because you'll probably, well, depending on the amount that you're going to be running through your account every month, you know, at some point, PayPal or GoPayment or Square or any of those, or you know, you'll overrun, if you will. That's not the right word, but your fees will end up being higher at some point than it would be if you went to your bank and just got a regular merchant account with all of the associated fees. And so it just depends. And I've heard if you're doing somewhere around $2,000, $2,500 or more per month, you may want to have a regular merchant account, because your fees will actually at that point be less.
Yeah.
Teresa is asking, does a nursing home qualify as a facility for Medicare billing?
Yes, I believe so.
Okay.
Yeah,
I would think so. I would think so. Tracy, happy Nurse Practitioner Week. Thank you, and happy to all. My question is about marketing a telehealth business. I am an FNP with a certification in functional medicine, and I'm interested in using this to increase my reach of my practice.
Well, that is the million-dollar question. That may be better for Barbara. You know, we do some marketing for our clinicians, although we switched lately into that model where we just go out and find contracts for them as a way of, rather than doing the marketing. But you know, from my perspective, it's just doing lots and lots of reading, getting very good at SEO work, or contracting that out, and then understanding, really narrowing who your target who your target market is, and making sure that it's a really teeny tiny small niche that you're trying to serve. Someone that can say, as soon as they hear of someone in that particular niche, they think of your name first and refer patients to you, is probably the best way to go. If you go broad, you sort of get swallowed up by the ocean. But if you're the biggest fish in a very small pond, suddenly other ponds start opening up to you.
Mm-hmm. Yeah, it's key to really know who your patients are, so that you can start targeting them as far as your marketing. And there's a lot of information on the blog at npbusiness.org. You know, I would start there and just start reading through, and if you've got more questions about marketing, let us know, and we'll certainly do that. You know, and for all of you, and of course, if you're going to do a telehealth practice, but for every single nurse practitioner, you should have a website, and you should have the information about who you are and what you do and the services that you offer on that website. And then go and get listed in Google. Okay, make sure that you have a Gmail account, that you get it on Google+, because guess where Google looks first for its information? It goes to its own websites. Brian is asking, as for psychiatry, regular malpractice insurance covers telemedicine, but it may not be the same for the rest of us, like for FMPs, and so it's covered in our liability insurance.
Yeah, exactly, and most insurances now are covering that. But if you call your particular company and they say no, there are companies out there that will add riders on top of what you do to help cover you for telehealth.
Okay. So Phyllis just has a question mark wound care. So I'm assuming she's asking, is this good for wound care? And I think what you said about the iPhone. And I should just say right here, and I forgot to say this up front for all of you, when you put in your questions or your comments, and when you're hearing us, there is almost a minute delay. Okay, it can be anywhere from 45 seconds and up of a delay. So normally you're not going to notice that, but if you were, say, listening to us like in the room with us, and then also trying to listen on another computer, you would find that there's this huge delay. So if I'm getting mixed up on these questions, that's why. So anyway, I'm assuming I'll go back to the wound care. I'll just make that assumption that she's asking about that.
That all depends. It goes back to, I know that there has been some, there are some clinicians who, I know in Alaska, Hawaii, it's being covered by Medicaid, where you can take a picture and send that to the clinician, or a clinician will take a picture, upload it, secure email it to a dermatologist to have it looked at, and then they'll make recommendations based on what they see. And that's being paid for. I think if you're talking about it from this sort of a venue, that you need to make sure that they've got the ability to where they have a camera that's plugged into the computer that they can lower it. They have to make sure that they have a good enough light source so it's not as grainy as I am right now. A lot of times an iPhone or an Android has the ability to turn on the LED lights, and that works very well. But once again, it gets down to, when you look at that wound, do you feel comfortable making a diagnosis? And if you do not, it's your responsibility at that point to say, no, I think you actually need to go in and see someone and have them take a look at this.
Okay. Brian is asking, he's wondering just what exactly your alternative to hanging a digital shingle is.
Okay, so typically what I'm talking about, the way I've used it in the past is I've worked with physicians who we use this for our established patients. The other way that it's being used is when we connect two centers that have staff available, should you need information and you have a medical record on them, and you make that sort of look, where you got that backup, and so that you can fully understand what the patient is, who they are, and what their history has been. I think you run into some potential board issues. I know medical boards are sort of shutting this down, and I would fair to say that as nurse practitioners become more entrepreneurial and start using telemedicine more, that we may see some things happening from the nursing boards, in that they want you to have some sort of a relationship with that patient prior to doing that. So if you are hanging a digital shingle, you're opening up a website, psychiatrynursepractitioner.com, and you sort of set that up, and anybody who can find you in a Google search comes to you for an evaluation. I think that there is a danger that you may misdiagnosis, or you may mismedicate some of those without an adequate amount of information on that patient. And I will say this too, there was a psychiatrist based out of Texas last year that lost his license because of two things. He was using Skype, which isn't HIPAA compliant, to deliver services to patients remotely that he had never seen before, and he was prescribing controlled substances to those patients without really an established relationship, and he lost his license because of it. So you have to be somewhat, at least be cognizant of that, and some of the treatment decisions that you're going to be making. I think ultimately it's probably the best thing to do before you decide any of that sort of work, is that you contact your nursing board to see if there's anything that you need to be careful of, and that you consult a good healthcare attorney to evaluate your particular state. And I've got a law firm that Smart House Calls uses, that the attorney has extensive knowledge in both entrepreneurial startups and telemedicine in particular, that I can make recommendations on, and I can get that to you, Barbara, that you can put that up on the website if you'd like.
All right, great, great. You know, the other thing is, while you were talking about, you know, just having that virtual with a patient, the other thing that I just want to throw in there, because what it made me also think about was some of us, I mean, we have access to all kinds of continuing education, and a lot of it is online, but I am aware of boards of nursing that have taken a negative view of if all of your continuing education is online and you never actually do anything hands-on. And so if there's ever an issue that comes up, that's going to be something that's going to be looked at by a board. So do you know that patient? Where are you getting your education? Have you ever gone and done any kind of hands-on continuing education? So just keep that in mind. While we are, you know, poised to go into this, you know, digital future, you know, healthcare is still kind of behind the times a little bit. They haven't caught up to everything that is happening in our current world.
Barbara, before you go on to that next, let me just, actually what I could do is I could pull up that attorney's website,
Okay.
if you don't mind.
No, that's okay. And I just want to make sure, Troy, for you, we're already closing in on 6 o'clock. So, do you have?
I'm available. Whatever
Okay,
whatever everyone needs. So what I'll do is, if you don't mind me taking over and just showing, I can.
Yeah, go ahead. Share your screen.
Okay. Let's see. I have to find it. Okay. So, Barbara, can you see that?
I can. Yeah, now I can.
Okay, so the company is Bowling & Company. They're a law firm. They're based out of Atlanta, and this particular attorney has extensive experience in telemedicine. In fact, was the lead counsel for a major university health system, as well as a telemedicine startup that's now gone through, I think, 3 rounds of venture funding. And is seeing patients not only across the U.S. but I think overseas as well.
Okay, great. And then you're going to send me that information so I can just put it on the website?
I sure will.
Okay, great. And I'll post this. I can also post the video on NP Business, but all of you will be getting a replay link as well. Okay, Angel. You mentioned the scenario for a nurse practitioner, diabetic educator hanging a shingle and providing telehealth services for the diabetic patients at an established primary care office. My question is, does the clinic pay and bill you, the nurse practitioner who's the business owner, or would you bill for the visit yourself? Angel is a diabetic educator and an adult gerio nurse practitioner, very interested in developing solo house call / telemedicine practice.
Okay. Yeah, I would say it could go either way. I think a model where, I would say this. Okay, so if you're connecting to a clinic that happens to be suburban or rural, you could see that patient and bill for the services. And from at least CMS's perspective, from Medicare, they would also pay that referring clinician $25 for a facility fee. So not only could you get your reimbursement, 99213 or 99214, whatever you would charge, that would be, or whatever you would code that would be appropriate, but then the practice could also charge a facility fee for providing the space for the patient to be seen by telemedicine. So that's one way that you could do it. The other way, because that may get a little sticky when they're talking about sort of a medical home model or some sort of a, if CMS is looking to see how well that particular clinician is doing with their diabetic patients. The other sort of avenue is to work out a contractual agreement with that clinic to say, hey, I'm going to see your diabetic patients. through telemedicine, and I'm going to charge 75% of the visit, and then you charge, you're able to retain that 25% for bringing the patient in and seeing me. So in a sense, both sides work out. This is not a kickback statute because, well, I shouldn't say it's not. I'm not a lawyer. You should check on this. Obviously, contact Bill. He could help out. But the idea that rather than, it's almost even sort of an employment contract where you would get a percentage of what you bill, which is not kickback. And that's essentially what would happen in that case, where you would see the patient under that clinician's practice's unique identification number in your NPR or NPI, and then you get a percentage of that for the services that you provided.
Okay, great. I don't see any, let's see. Well, one more question just came in. And so Kim is asking, what software do you recommend? Which actually takes me into what I was just going to say, which is, Troy, why don't you talk a little bit about Smart House Calls, since you've given us all this great information.
Oh, sure.
So if people want to follow up with you, they can.
Okay. Well, let me start out by being generalized with this, because I want to make sure that this is more about everyone who's listening and not so much about Smart House Calls. I would say that from a practical standpoint, if you're going to be using software, it should be something that's affordable. It needs to be dynamic in a way that it will connect to multiple different devices. You know, for instance, Cisco, Polycom have these beautiful cart systems that they use. They're absolutely incredible. The things that they can do. They cost $50,000 a piece, and you're limited into where you can connect with. So you need to make sure that the software that you're going to be using, at least from my understanding or my thoughts about it, is that it has to be very practical, which means it has to work essentially everywhere. And you know, one of the things I like about Smart House Calls when we developed it was that this software will connect to iPads, it'll connect to Android phones, it'll connect to Linux computers, both laptop and desktop, PCs and Macs. So across everything, and no one has to download anything. It works right within the browser. It goes through our secure servers. So as long as somebody can open up a browser or open up an email, you can see them with the software. So when you're thinking about your own sort of system, there's lots of vendors out there outside of Smart House Calls. And as long as A, they provide you with a business associate agreement that says that they are in fact HIPAA compliant, and B, as long as it's at the right price point, and then finally C, that it works with everyone that you're trying to reach, then that's a good software solution for you.
Okay, and those are things that Smart House Calls, I'm assuming, does. Mm-hmm. And the other question Dennis just asked is, do you know of a company that does hand-holding or turnkey telehealth business or any kind of franchise for those of us that don't have very much entrepreneurial experience?
I don't know specifics. I know that we work very hard from the Smart House Calls perspective to try to put that together and help out. We've done, for some of our providers, website SEO work, some initial marketing, press releases, those sorts of things, and then some coaching in that. And that may be something that maybe Barbara and maybe you and I need to speak about and see if we can put a package together for NPs to help them sort of get started.
Yeah, that would be good, because I think you can't. The worst thing that any nurse practitioner could do is just go out and say, okay, I'm ready to start my own business. And I've actually had people email me and say, hey, I got my space. Now what do I do? They go out and rent their space, and they don't even know what the first thing that they need to do. They haven't done any of the back work, and that is so critical to be able to do that. Now, I just put Troy's website address into the chat for everybody as well. And let's see, do we have any other questions? Okay, what is the price per month for the provider, et cetera, for telemedicine software systems, et cetera?
Okay. Well, from Smart House Calls perspective, generally speaking, it's it varies. If there's a lot of providers, we decrease the cost. If it's one provider, typically if it's one provider in a clinic, it's $149 per month. Um, I have been known to discount, and I have that opportunity to do that because I'm the guy who tells everybody what they can charge. So obviously we can provide discounts, and I will say that for anybody so far that has contacted me because of the wonderful work that Barbara's doing, I have given them discounts because obviously I'm partial to NPs. Um,
Thank you.
so I will say that that's most likely going to happen. Um, and then we also do have sort of certain structures where, based on the number of providers, that each additional provider that comes on is decreased significantly on the monthly price, that sort of thing. And generally speaking, the way we do it is that it's regardless of how many patients you see, how much you use the system, there's no change. So if you're using it 40 hours a week, we're not going to charge you more because you're doing that over someone who's using it 2 hours a week.
Okay. All right. And that looks like it's the end of our questions, and so we're just a little bit over 6. So this is great. So Troy, thanks so much once again for doing this, and thank all of you nurse practitioners out there for all the work that you do. I am so pumped to be part of the nurse practitioner community. And to those of you who are veterans, happy Veterans Day tomorrow, and thank you for all you do.
All right. Thank you, Barbara.
All right, so good night, everyone.